Well, welcome back, everybody, after that short break. We are delighted to have our next speaker here, Dr. Jahan Aladina, who will be talking about ARDS. Just a reminder to please pop your questions into the Q&A. We have a nice collection going for our session at the end of the morning, so please continue to put in your questions. And thank you so much, Dr. Aladina, for joining us this morning.
Great. Thank you, Dr. Hibbert. And for those of you who don't know, Dr. Hibbert used to give this talk and has really taught me everything I know. So you can thank or blame her based on this talk. So our objectives for today is really to talk about ARDS as a syndrome, understand its impact, and really focus most of our time on evidence-based treatment for ARDS, and then spend a little bit of time talking about some of the ongoing questions in the field. So these are all examples, as I'm sure many of you are familiar with, of patients with ARDS, and just to highlight that there is quite a diversity in sort of age, presentation, etiology, and oxygen requirements for a lot of these patients. So we have our young 32-year-old patients with influenza, which we saw a lot of this past winter on high flow nasal cannula with a fairly high FiO2 and then low PaO2. We have an elderly patient who does have comorbidities, including some evidence of heart failure, but despite a fair amount of positive pressure ventilation, is still hypoxemic and has evidence of likely sepsis or infection. We have patients who present with COVID-19 pneumonia who need to be intubated, which fortunately we're seeing much less of, but still not zero. Again, presenting with bilateral infiltrates and a fair amount of hypoxemia. And then probably our more standard bread and butter patients with strep pneumonia, strep pneumonia, with requiring a fair amount of PEEP and fairly impaired oxygenation. And so when we think about whether these patients meet the criteria for ARDS, the criteria that were really set out in 2012 are the Berlin definition. And really the main features are it has to be some sort of acute insult within a week of presentation that leads to new or worsening symptoms. Chest imaging is really notable for bilateral opacities that are not otherwise explained. The Berlin criteria does allow for cardiac heart failure or fluid overload, but the respiratory failure cannot be fully explained by heart failure. And really one of the key features is the impaired oxygenation that we see with a PaO2 to FiO2 ratio less than 300, sort of encompassing all ARDS, both mild, moderate, and severe, even though they are on some degree of PEEP, here defined as 5. Now, this is a very inclusive definition, and the reminder that ARDS is truly a syndrome that encompasses a variety of, again, other diseases, presentations, and patients. And I also wanted to spend a minute just talking about sort of the new global definition of ARDS and how that may impact how we think about and diagnose our patients. So many of the criteria are the same in that it has to be a fairly acute insult, again, within a week. Bilateral opacities are seen on imaging, but the imaging now is inclusive of lung ultrasound with the caveat that it's performed by a well-trained operator. Again, the origin of edema is not fully explained by other causes, most notably heart failure. And really the main difference is that the impaired oxygenation now allows for patients on high flow nasal cannula with a flow rate of at least 30 liters per minute. And in addition to looking at a partial pressure of oxygen, you can also look at the SpO2 to FiO2 ratio, with ARDS defined as a ratio less than 315 with an SpO2 less than 97%. And again, there has to be some degree of PEEP or a pretty moderate flow on high flow nasal cannula present. So this really just shows that the community is trying to be even more inclusive. So recognizing that many of our patients now are managed with high flow nasal cannula and are quite hypoxemic, even if they don't end up on the ventilator, and also wants to allow for the diagnosis of ARDS in more resource limited settings that may not have the capabilities to obtain a CT chest, for example. So this is this should really be more inclusive of the patients we include both clinically when we're diagnosing ARDS, but also for research purposes. So a little bit about the pathobiology of ARDS. So this image is really focused on the acute or exudative phase of ARDS, which is thought to be within the first 7 days, so very early on during the insult. And it's really characterized, as you can see, by intraalveolar flooding. So you have the protein-rich edema fluid, which is really a hallmark of ARDS and leads to the bilateral infiltrates that we see on imaging. You have inflammatory infiltrates, most notably neutrophils, releasing a lot of inflammatory factors and cytokines. And then you have quite a bit of damage to the alveoli itself, including epithelial damage and endothelial damage, as well as impaired coagulation. So all of these factors have long been known to contribute to ARDS. And on histopathology on the right, what you can see in A in the top left, the arrow is pointing to a hyaline membrane, which is the classic finding in ARDS. And this is really representative of acute ARDS. So this biopsy was taken 2 days after the onset of an injury. And then in B and C, you actually see more chronic ARDS, so about 14 days after onset were when these biopsies were taken. And what you can see in B is the development of granulation tissue, and C, the blue is actually staining for collagen. So this is really more the fibroproliferative phase of ARDS that can progress to true fibrosis, which, as we all know, is really hard to manage and really, as of now, has no reversible treatments. What you can see in D and E is that there's a combination of both epithelial and endothelial damage. And what you're seeing in E with the arrow is actually reepithelialization with AT2 cells, which are alveolar type 2 cells, which is thought to be delayered or impaired in ARDS, and is one of really the focuses of trying to understand how to resolve this disease and the damage that occurs to the alveoli. And so, despite our best efforts and all our evidence-based treatment that I'll talk about, the mortality does remain quite significant at about 30 to 40% per year, with some variability in terms of the type of patients and their mortality. So, for example, this chart here shows that patients with sepsis tend to do worse than patients with other risk factors, and that mortality increases by age. So certainly the older you get, the higher your risk of mortality with the development of ARDS, but also notably young patients still have quite high mortality on the order of 25 to 30+%, even for patients who are under 40 years old. And one important facet of ARDS that I think we're learning more about every day and every year is understanding what it looks like for survivors, and knowing that even if patients recover from their ARDS, leave the ICU and leave the hospital, there's a pretty significant long-lasting impact. And there's a really nice review on the New England Journal that really goes through all the different elements to think about that perhaps aren't always on the forefront of our mind for patients who leave the ICU, but really have suffered the sequela of ARDS. And we have a talk coming up that talks a lot about post-ICU syndromes that will touch on this as well. Hopefully that we won't need to focus on this too much more going forward, but I think it has been pretty well described now that the COVID-19 pandemic was an ARDS pandemic. So most of the deaths, especially early on, were due to respiratory failure that was ARDS due to COVID pneumonia. Most of those patients met the Berlin definition from ARDS. Their pathology was consistent with ARDS, and most of their physiologic characteristics, including mechanics and lung compliance, were all consistent with ARDS. It's important to note that especially during COVID, there was a lot of renewed interest in many of the agents that have been studied for decades in ARDS, a lot of them listed here. Unfortunately, there really has been no clear benefit to really any of these therapies. And the reasons this might be are, as we discussed, ARDS is a syndrome, so it really encompasses a broad swath of patients and diseases and insults. And so because of that, there's likely a lot of heterogeneity within those populations. And also we're sort of catching ARDS at different times with different patients. I actually think this is really critically important. Even though, it's an acute insult that occurs within 7 days, some patients, as we know, have been sort of on high flow for days and days before they get intubated and before we had this new criteria to label them as ARDS. And those patients likely have different physiology and immunology as well compared to patients who come in very sick and are intubated right away. Um, I think some of these, there is some interest that perhaps there are benefits that have not been fully appreciated, that have sort of been hidden by looking at all comers, and perhaps there are subgroups that may benefit, and we'll talk about that a little bit more. I think steroids are a prime example, and we'll sort of talk about that next. So steroids have been of interest in critical care for a long time, and ARDS is no exception. This is one of the more recent studies, the DEXA ARDS study in 2020, that looked at steroids and ARDS. It was a moderately sized study, about 300 patients, and they compared the administration of dexamethasone to control in patients with moderate to severe ARDS, so a P to F ratio of less than 200. But this study, while it showed a mortality benefit that was, quite impressive, as you see the separation here, 21% versus 36% in the control group, and more ventilator-free days, there are a number of criticisms of this study. Primarily, it had quite low enrollment and was stopped early. Really, about 3 patients were enrolled per site. Additionally, there are some concerns about enrollment or bias, as physicians were unblinded, and ultimately it was up to the physician to decide whether steroids were indicated or not. And so I think this hasn't changed practice, at least for myself, and I think for most of my colleagues, but there does seem like perhaps there's a signal to benefit. It's just hard to really interpret this study that was on the smaller side and has some concerns about enrollment and bias. Additionally, this is in the larger context of prior studies in ARDS actually pointing towards a signal for harm, especially if steroids were started later in the course of disease. So I think especially because is the concern for potential harm, this really hasn't taken on as practice changing for ARDS. That being said, I think steroids are indicated for a number of diagnoses that can be concurrent with ARDS. So for example, whole separate discussion that you guys will have, but steroids in septic shock, steroids in COVID, I think we have some good data for, and now steroids in severe pneumonia. So I think for those indications, certainly we are prescribing more steroids, but for ARDS itself as a syndrome or diagnosis, I don't think that there's any data to support the indiscriminate use of steroids in these patients. So really the mainstay of treatment for ARDS is truly ventilator management, and that's where most of our benefit or mortality data has really come from. And so the idea behind this, as most of you are all aware, is that conventional ventilation, which sort of predated the ARMA trial, usually used larger tidal volume ventilation. And with that, you spent more time sort of without a specific positive end pressure, positive end expiratory pressure. So before there was a lot of discussion about PEEP titration, which could lead to alveolar collapse, as you see on the left there, and also potentially time at overdistension with high tidal volumes, as you can see on the right. And the idea with lung protective ventilation is that you're spending more time at sort of your optimal lung compliance, which can also lead to improvements in gas exchange. And so what this tries to prevent is the sort of the induction of ventilator-induced lung injury. And what that is characterized by is volutrauma or barotrauma, which happens in the setting of overdistension, which itself can lead to lung injury, but also can, in extreme circumstances, lead to barotrauma, such as pneumothoraces. Atelectic trauma, when the lung is collapsed and atelectatic. And also we know that both of these things, so the changes that you see in lung strain on both ends of the spectrum, can lead to the release of inflammatory mediators and biotrauma that don't only affect the lung and lung inflammation, but also can cause systemic effects as well. So that seems to be the rationale for why lung protective ventilation has really improved mortality, that we'll talk about a little more. And for those of you who sort of remember your pressure volume curves, really through a combination of lung protective ventilation and optimal PEEP titration, we really want patients on the steep part of this pressure volume curve, which allows for optimal, as I said, lung compliance and gas exchange. So avoiding the flatter parts of the curve on the left, which represent atelectasis, and on the upward right, which can represent overdistension. And so just to get into this a little more specifically, this trial now is 25 years old, which is really hard to believe. But this is the original ARMA trial that was conducted to compare a lung protective strategy, using lower tidal volume ventilation at 6 cc's per kilo of predicted body weight, sort of aiming for a goal plateau pressure of 25 to 30, with what was considered conventional ventilation at that time, using tidal volumes that were 12 cc's per kilo, with a goal plateau pressure of 45 to 50. And they did have nice separation of mean tidal volumes, about 6% in the treatment group versus 12% in the control or standard therapy group, 12 cc's per kilo. And they showed just a really significant difference in mortality, with an absolute reduction rate in mortality of 9%. So really one of the biggest separations in mortality that we've seen in our critical care trials. So this is really the mainstay of treatment. Now, whether or not this is the only thing we can do to protect the lung and improve outcomes is not clear, and actually is likely not the case. So we know that it's not just tidal volume that is important, but really if you look at the pressure volume curve of the lung, it's nonlinear, meaning the slope of the curve, which is compliance, may be greater at higher lung volumes. And the pressure required to open this lung unit is therefore higher than the pressure required to keep it open. So that's actually the rationale for thinking more critically about PEEP and for trying to optimize PEEP titration, which we'll talk about next. So what is the data to support positive end expiratory pressure and sort of judicious or titration of PEEP in ARDS? So I think some of the intuitive pros are that it can prevent end expiratory derecruitment. And this was an early study from the 1970s that looked at things we think about like oxygenation and lung compliance, but also use pulmonary artery catheters to look at cardiac output and oxygen transport, looking at cardiac output and oxygen content. And what this showed is that with an increasing PEEP, you did actually see an improvement in lung compliance, as well as an improvement in oxygenation or gas exchange. And this sort of was optimized at a certain value, which was termed in this study as your best PEEP. With that, you saw a decrease in shunt as well, and this likely represents a patient who does indeed have recruitable lung. So with an increasing application of PEEP, you see that there's less atelectasis, more recruitment of the lung, which improves compliance and gas exchange as well and decreases shunt. Now, the potential cons of PEEP is that with the already open lung units, this could lead to overdistension, as well as causing impaired hemodynamics. So, most notably hypotension that we see at the bedside. And so, as you can see, after the sort of optimal PEEP titration, you get diminishing returns in that compliance decreases, as well as oxygen transport. And this is really thought to be largely driven by the drop in cardiac output at higher PEEPs that really impairs oxygenation. And this likely represents the point where there is no longer recruitable lung, so there's no added benefit. And indeed, there's the potential for harm with overdistension and again, worsening compliance and worsening oxygen transport by decreasing cardiac output. And so when we think about PEEP, one of the early standardizations of PEEP was actually in the ARMA trial, which had a table for management of PEEP. And there were actually two flavors to it. There was a low PEEP, high FiO2 table and a higher PEEP, low FiO2 table without a clear prescription of which needed to be used. And so, after this study, and there have been a number of other studies that have come out that wanted to directly compare a lower versus higher PEEP approach, with a higher PEEP approach really deemed an open lung approach, thought to sort of recruit the lung and allow for, again, improved compliance and gas exchange. So the number of studies that looked at this, including the alveoli trial and express trial, directly compared high and low or sometimes moderate PEEP. And really the takeaway from many of these studies is that higher PEEP and recruitment maneuvers do not seem to reduce mortality in ARDS, but in some studies they did see an improvement in hypoxemia and a decreased need for rescue therapies. And in most of these studies, there was no significant harm. So is that perhaps there still may be a subgroup of patients who benefit from higher PEEP that we haven't truly identified. And so again, coming back to this idea of there being significant heterogeneity in ARDS, to that effect, there's likely a heterogeneity in how patients respond to treatments, also deemed the heterogeneity of treatment effect. So because patients in a lot of the trials that we perform and in critical care medicine in general have wide variability in their risk of death, these patients will also have a wide variability in the benefit that they can achieve from a certain therapy. And that's what's indicated here on this study that simulated a lot of randomized controlled trials. And what it shows is that at the top, you can see that the highest deciles of risk showed consistent benefit with an intervention. Again, this is a simulation. And so if you take these patients as a whole, you can see that there may be a subgroup of patients who benefit. However, they're the patients with the lowest risk. You don't always see a benefit. When you group these together, a lot of times the trials end up being negative. So the heterogeneity of treatment effect and negative trials can sort of hide the benefit that you can see in certain subgroups. So again, how this could relate to talking about PEEP is that perhaps there's a subgroup of patients who have recruitable lung that you can see at the top that may benefit from a higher PEEP or recruitment strategy. But how we identify these patients is really the important question. And so when we think about heterogeneity in ARDS, we talked about, patients who have recruitable lung versus not, but there's a lot of different ways to think about subphenotypes in ARDS. So we can group patients by Berlin severity, so their degree of hypoxemia. We can group patients by whether they have sort of direct injury to the lung versus an indirect injury from some other cause, such as, for example, pancreatitis that leads to their ARDS. Focal or non-focal disease. So there's a lot of different ways to sort of divide up ARDS. And I think one of the ones of most interest lately is the systemic host response. So this idea that some patients perhaps are more hyper-inflammatory versus patients that are hypo-inflammatory. I think those terms are likely falling out of favor, but there is some evidence that the initial immune response may indicate patients who are more or less likely to respond to certain therapies. So that's an area of ongoing interest in research. And so when we think about how do we identify patients who perhaps may have recruitable lung, for example, one technique that we use often at our institution is best PEEP titrated to best tidal compliance. And again, this based on this early study, they coined this term best PEEP because there's a PEEP that's associated with your best tidal compliance that also will optimize gas exchange. And that's the idea. And how we do this is we do a best PEEP study or a PEEP titration where you keep the tidal volume constant and we perform a decremental PEEP titration where you keep the patient at a single level of PEEP, typically for about 5 minutes before taking measurements to achieve equilibrium. And what you're looking for is an optimization of here driving pressure because you're keeping tidal volume constant. So that gives you your best tidal compliance. And the value that optimizes driving pressure compliance with the best oxygenation and minimal effect on hemodynamics. Now, this is an easy bedside maneuver. It doesn't require any specialized equipment, which is really the strength of it, and it's quite personalized to the patient. It does, however, require time and expertise in the person performing the procedure. Another method to identify best PEEP is to look at the stress index. And here you keep flow constant and you can look at the shape of the pressure wave or the pressure waveform to look for evidence of recruitment versus overdistension based on the slope of that waveform. Now you can obtain some information just from looking at the ventilator, but really to use a true stress index, it requires specialized software that's not always available or people don't always have the expertise or time to use. I wanted to touch a bit on esophageal balloons because they seem quite promising in that esophageal pressures that are measured by esophageal balloons do provide a surrogate for pleural pressure. And because of that, you can calculate the transpulmonary pressure. So the pressure across the lung being the airway opening pressure minus the pleural pressure, again, which is estimated by the esophageal balloon. And so that gives you the distending pressure of the lung. And the benefit of that is that it ensures that the PEEP that you set is always greater than the pleural pressure that is measured by the balloon, which reduces derecruitment. And another benefit is in that patients who do seem to require a high level of PEEP, it can provide confidence or confirmation that you are not over distending the lung by calculating the distending pressure based on a truly measured pleural pressure surrogate. Um, Now, again, this requires specialized equipment and expertise, and it is also one single pleural pressure measurement across sort of the whole gradient of the respiratory system. So it may not give you a good global sense of what's on in a patient, but can give you some information about transpulmonary pressures at a certain point in the respiratory system or along the lung. Now, this has been studied, and there have been a couple of big trials. EP-Vent1 and EP-Vent2 are the two major ones. EP-Vent1 did show that there was a benefit to oxygenation using an esophageal balloon in the intervention arm, but no mortality benefit. However, they used a more low PEEP approach in the conventional arm. So one of the big differences in EP-Vent2, which is shown here, is they recruited 200 patients with moderate to severe ARDS across multiple hospitals, and they used a esophageal balloon guided approach to PEEP titration versus a high PEEP table. And what they saw here was that there really wasn't a mortality benefit between the two approaches. So while in some specific patients, there may be a benefit to using an esophageal balloon when there's a lot of sort of difficulty optimizing PEEP or uncertainty around a PEEP titration, in general, in studies, there's really no data to support the routine use of esophageal balloons. Another approach to identifying best PEEP is using a driving pressure approach. And driving pressure, if you remember, is the plateau pressure minus the PEEP. And so if compliance is your tidal volume over your plateau minus PEEP, if you sort of change around the values, you get tidal volume over respiratory system compliance. And so a very simple bedside measurement of plateau versus PEEP gives you information about both the tidal volume and the PEEP and allows for manipulation of both of those factors. So driving pressure represents the pressure needed to inflate the lungs, while compliance is more of the ability of the lung's ability to expand for a given pressure. So there's a subtle but important difference between the two. And the big driving pressure study that showed a mortality benefit was this Amato study from 2015, which importantly is a retrospective analysis, so not a randomized control trial of previously prospectively collected RCT data. And what they showed here is that driving pressure was the factor that was most strongly associated with survival. And that was the case, and a decrease in driving pressure led to improved survival, even in patients who were receiving protective lung ventilation or protective plateau pressures. And changes in tidal volume or PEEP were not independently associated with survival. They were only associated if they led to a change in driving pressure. So that really led to the interest in looking at driving pressure as a very easy sort of bedside number to calculate. And also because of this study that showed that this was truly the independent predictor granted in a retrospective analysis of improved survival. Now, it's important to note that if you look at the median tidal volume across driving pressures in this trial, in the sort of low driving pressure improved mortality arm, they had tidal volumes of 6 cc's per kilo. And in the sort of worse driving pressure or higher driving pressure increased mortality arm, tidal volumes of 8 cc's per kilo. So you're really, there isn't really data to support that a very high tidal volume, sort of over and above what we would typically use, so 10 or 12 cc's per kilo, may not still cause harm because those patients really were not looked at in this trial. Additionally, while driving pressure is a great bedside measure and is a really nice way to evaluate lung strain, the method that you arrive at a certain driving pressure is important. So, for example, when looked at in the ART trial, which is a trial that compared usual care, which is lung protective or low tidal ventilation using the low PEEP table from the ARMA trial, versus lung protective or low tidal volume ventilation and PEEP titration, um, to sort of optimize recruitment. This study was interesting in that it the early trials that used high PEEP and recruitment strategies called the open lung approach that I referenced earlier with some of the trials showed no mortality benefit, but this was revisited in this very large trial in 2017 that enrolled over 1,000 patients with moderate to severe ARDS across 120 ICUs in 9 countries. So they really sought to answer this question about whether an open lung or recruitment approach could lead to a benefit in patients. And so patients had a formal recruitment maneuver followed by decremental PEEP titration, or as I said, the conventional ARDS-net low PEEP strategy approach to PEEP. And now what was really notable here is that there was actually a signal to harm or harm seen in the intervention or recruitment maneuver arm with a 55% mortality in that arm versus 50% mortality in the usual care group. So high mortality in both groups, but a pretty significant mortality in the intervention group. And this was really thought to be driven by this recruitment maneuver, which was felt to be pretty aggressive in that they had pretty high PEEPs that they were targeting that led to cardiac arrests in the treatment group. And they actually had to modify their protocol, as well as some barotrauma, which I would say is pretty rare that we see with our PEEP titrations across most centers. There was also, while a benefit and that there's a lot of centers that were included in a lot of countries, there was a lot of variability in sort of the protocol application, and again, very high overall mortality. And so one other important point in this study is that the driving pressure improvement or difference between the intervention and control group were actually quite similar. So 13 centimeters of water in the treatment versus 11.5 centimeters of water in the control group. And since tidal volumes were also similar between the groups as well, the small difference in driving pressure suggests that there probably wasn't a lot of recruitment that was actually happening. And so again, it does not support an open lung or lung recruitment approach, or there remains an outstanding question about whether there is a subgroup of patients with recruitable lung that we can identify. And so really the takeaway from all of this is that there's no mortality benefit in these large PEEP trials versus high versus low PEEP. However, a personalized approach or a best PEEP approach may be best for the patient in front of you, but that really depends, mostly on the time available at your institution, as well as the local expertise and technology. So I'll just hit, I spent the majority of the time talking about PEEP, but I just want to hit on a few other important points. So I think there's good data. I think that we all know from a while ago that fluid balance is important in ARDS, in that this sort of seminal FACT trial showed that if you maintained a lower fluid balance, interestingly, not truly negative, it was really net even versus a fluid balance of positive 7 liters, these patients actually had increased ventilator-free days and ICU-free days. An important caveat in this study was that these patients were not on pressors, but I think we have since applied some of the takeaways that perhaps dry lungs are happy lungs. And a lot of us in our institution do actually diurese patients who are on pressors. And we do think that there is a benefit to their lung oxygenation as long as their hemodynamics can handle it. Prone positioning is one of the interventions that really has shown the greatest mortality benefit. So this is the original PROSEVA trial back from 2014 that showed a significant mortality benefit with a very low mortality in the prone group of 16%, sorry, compared to about 32% in the supine group, which is really considered sort of an average ARDS mortality. They really looked at severe ARDS in this trial, so a P to F of less than 150. And really the key point is that they prone these patients early. So this was not a rescue strategy for refractory hypoxemia, which I think is how we even at our institution sometimes employ prone positioning. But really it should be employed up front if you want to achieve the mortality benefit by following the same protocol that they did in this trial. Just wanted to touch briefly on paralysis. So this is data from the PEDAL network, the ROSE trial that was published in 2019 that compared deep sedation within 4 hours, the randomization in the trial, to with a bolus of cisatracurium followed by an infusion compared to controls who actually had pretty light sedation defined by a RASS score of 0 to -1. And what they saw here was no difference in mortality or secondary outcomes, such as time on the ventilator or in the ICU. And it's really thought that one of the reasons that this trial looks different than prior studies favoring paralysis is both of these groups received lung protective ventilation and a lot of the other measures that are now considered more standard of care. So perhaps there's less of a difference to be seen by paralysis in this study. Inhaled pulmonary dilators can take a few forms, so inhaled NO or inhaled epoprostenol, which is more common and cheaper and a similar efficacy to inhaled NO. And what the studies on inhaled pulmonary vasodilators show is that they do improve oxygenation, and this is thought to occur by improving the cardiac output from the right ventricle and improving VQ matching. However, in repeated studies, there has been no mortality benefit shown from these interventions. So really, these are often used as rescue therapies while you're trying to employ other methods to improve patient outcomes. If you really need that oxygenation buffer to get patients through, to the next intervention or for a certain amount of time, but there's no upfront mortality benefit from these therapies. And then I'm just going to spend a moment talking about ECMO. So ECMO is being used more and more for ARDS, which is what we see here, cases of ECMO over time and the number of centers. And we see increases during viral pandemics because there are increased cases of ARDS, but also these pandemics are often enriched for younger patients. And as you can see here during COVID, the cases increased dramatically, but interestingly, the number of centers that offered ECMO did not scale up proportionally because it's a very resource and time intensive application and requires a lot of particular expertise. And so it's not as easy to scale up. So a lot of these individual centers were just seeing more cases like we did here. And so when we look at patients, this is from a single center who end up going on ECMO, a lot of times they're quite hypoxemic, quite sick. And interestingly, they have a variety and application of therapies that are known to sort of, be helpful or not so helpful in ARDS. And I think a lot of the variability is just due to their severity of illness and their stability. So the mortality in this case report was 23%, but these were patients who are actually quite young overall with very few comorbidities. And so the largest randomized trial to look at ECMO versus standard of care is the Aeolia trial, which was published in 2018. And so it's 249 patients were randomized to ECMO or conventional therapy, and it was an intention to treat study. And so that's a really important feature because 28% of patients in the control arm actually crossed over into the ECMO arm. So the study was stopped early because there was no benefit seen, although you can see a separation between the ECMO and control group. So I think this remains sort of an open question or a Rorschach test in that it really preys on your preconceived notions of whether or not you think ECMO is helpful and harmful. But again, it's really difficult to think of this as an ECMO versus control study because so many patients in the control group actually ended up receiving ECMO. So it's really more a study of sort of early versus later ECMO. So I think it's really hard to draw a firm conclusion from this. So in summary, I think that really the standard of care in ARDS really is around ventilator management, so low tidal volume ventilation, judicious PEEP, and conservative fluid management, probably in that order, as well as for more moderate to severe ARDS, prone ventilation early on as opposed to rescue therapy, paralysis in patients who perhaps there's a high suspicion for ventilator desynchrony or other issues, but again, for all comers, there has not been shown to be really any difference in outcomes. Inhaled pulmonary vasodilators, more as a rescue therapy, and then ECMO, and whether or not that truly leads to a benefit in outcomes, I think remains an open question. And so then sort of going forward, I think one area that I'm really interested in is a better understanding of the mechanisms of lung injury and resolution. I think there's a lot of study in sort of adapting our clinical trials to identify those patients who actually may benefit from specific therapies. And I think as we go forward, hopefully we'll find better ways with both biomarkers and sort of changes in how we design our clinical trials to identify those patients who actually may improve with specific therapies to actually help some of our patients with additional treatments beyond just ventilator management. That's it. Thank you.